Jumping into the elbow, essentially the protocol here is you're going to have essentially two coronal sequences. One is going to be your non-fat saturated, which is going to be kind of more of an anatomical sequence and taking a look at the marrow, see if there are any osteophytes, what do the bones actually look like. And then pretty much the same thing for both of the axials and both of the sagittals. This is going to be another one of the studies where it's going to be important to look at the localizer sequence, because you could get portions of the body or potentially even portions of the brain that pop into view. And it's really no liver mass, no renal mass, no adrenal mass, or if a portion of the brain pops into view, no brain mass or anything like that. So after we're done looking at that, essentially how I like orienting this is with the humerus coming down, and then you see the radius and the ulna on both of the coronals, and then on the axials, having your ulna kind of more posterior, and then the humerus and bicep musculature kind of more anteriorly here. So we'll start with the coronal T1, and I'm really just kind of looking at the osseous structures, seeing if there are prominent degenerative changes, osteophytes for the ulnohumeral and radiohumeral joints, and making sure there's no abnormal bone lesion. What this can also be helpful for is just another look to make sure ligaments and some of the tendons look grossly okay. So just kind of starting with the anatomical position being more medial. We're looking at the ulnar side here. You can see this is the ulnar collateral ligament, which is clearly intact. And you're going to have the common flexor tendon, which will insert here on the medial epicondyle, which is also looking grossly okay. And then we're going to do the opposite. Same thing on the opposite side, where essentially you want to look for an overlap of a bunch of structures. The tendon is going to be more superficial, and that's going to be your common extensor tendon. And then your structures deep to that are going to be your radial collateral ligament and your lucal or lateral ulnar collateral ligament. This can be a little bit tough for people to identify. I think a good general thought is as you're more anterior, as you can see here with our line, you're going to see the radial collateral ligament. And as you go more posterior, you're going to start to get into the lateral ulnar collateral ligament, and it tends to oblique and cross across and come more medially. And you can see portions of it here coming across. So in this case, I mean, I wouldn't say that there's a full thickness tear. It's grossly intact. And we do essentially the same thing in the coronal fluid sensitive. Look at all the bones. You're looking for abnormal marrow signal intensity. This is our ulna. This is the radius. This is the distal humerus. Look at your medial and lateral epicondyles to see if there's any underlying marrow edema. And then just kind of break it down into the compartments. So you're going to be looking medially and laterally. So here in the medial compartment, we can see a portion of the common flexor tendon, which is low in signal. It's not abnormally thickened. It's not abnormally flattened. There's no overlying subcutaneous edema or marrow edema in the medial epicondyle. This is a very good look at the ulnar collateral ligament here. It's intact. A lot of times, even if you don't see a full thickness tear, you may see some periligamentous edema proximally, which could suggest maybe there's a low-grade sprain. And then we're going to kind of look and do the same thing in the opposite side, the lateral side. So more superficial is going to be kind of a portion of the common extensor tendon, and deep to that is going to be your radial collateral ligament, which will be this kind of structure right here. And then as you come more posterior, this is going to be a portion of our lucal here that is coming across and obliquely traversing posterior to the radial head. There's not a lot of periligamentous edema. There's no clear full thickness tear. And so now we'll move on to the axial sequences. So on the non-fat saturated, this is going to be kind of an important sequence to kind of look at essentially the tendons, the common extensor, common flexor tendon, and then your anterior and posterior musculature to see if there's any disproportionate fatty infiltration or atrophy. And this will be important to look at the different nerves that we have in the elbow. So the more superficial structure here is going to be your biceps muscle. Deep to that is going to be brachialis. So following them one at a time, this is our biceps here, comes together. In this particular instance, the imaging didn't go distal enough to actually visualize the insertional site. So you want to make sure, if you are checking the images, to make sure that that's included in the field of view. And then we're going to do the exact same thing with the brachialis. You can see the muscle. These are going to be a little bit of the tendon fibers. The muscle is going to kind of go away as you get to the myotendinous junction. And then you're just going to get purely into the brachialis tendon here as it goes to insert distally on the ulna. The biceps will be going to the radius. And then as we come out again, looking posteriorly, this is going to be triceps, a portion of it here. And we're going to follow this to the olecranon as it inserts here. And then the next structure we'll look at is the ulnar nerve as it's kind of traversing through the cubital tunnel. So what you really want to look for is there effacement or infiltration of the fat around the ulnar nerve, either from scar tissue or maybe there's a space occupying mass that essentially would be compressing it and effacing the adjacent fat. And then when we come to the fluid sensitive, you're looking for, is there signal alteration? Is there abnormal thickening or abnormal flattening of the ulnar nerve to suggest that there may be ulnar neuropathy? While we're here, you can kind of see the muscles here with the tendons coalescing to form the common flexor tendon as it inserts in the medial epicondyle here. And then we're going to do the exact same thing on the opposite side for the common extensor tendon. The tendon fibers are going to start to come together. And then they're coalescing here to insert on the medial epicondyle. Next, you're going to kind of take a look at the structures on the fluid sensitive sequence here. This one is a little motion degraded and there's a little bit of incomplete fat suppression artifact causing some of the structures to look brighter than some of the other structures. But a lot of times, you're going to see these on a lot of your examinations and it's going to be one of those things that you just try your best to kind of read through. So this is going to be our biceps right here. And we're going to kind of try to follow it the best we can in this area right here. As we kind of come more distally, this is a portion of the bicep here, as it will go distally to insert on the distal radius. And then we're going to do the same thing with the brachialis. So these are going to be some of the tendon fibers coalescing along the cursor here. We're going to continue to follow it as it goes distally to kind of try to insert on the ulna here as well. Now we're going to come out, we're going to kind of take a look at that ulnar nerve, which is going to be this bundle right here, kind of has a fascicular kind of appearance to it. It's not grossly thickened in appearance. There's some subtle signal alteration with it, but it's not overtly abnormal as it's traversing through the cubital tunnel. Some of the ancillary findings you can look for are, is there overlying subcutaneous edema? Is there an external marker overlying that region as well? And now we're going to kind of take a look at that common flexor tendon again as it coalesces here. And you can see it's pretty low in signal, not a lot of thickening, signal abnormality, or fluid type signal to suggest an actual tear. And then we're going to do the exact same thing in the opposite side with the common extensor tendon. You can see it's starting to coalesce and come together here, and it's pretty uniformly dark in signal. No tear associated with that as well. And so now the last thing that you're going to do is you're going to get into the sagittal sequences here. I like orienting these to have your ulna kind of more posterior and with your biceps to be kind of on the top here. And so starting with the sagittal T1, what I like doing is kind of taking another look at the common extensor and common flexor tendons, this being the common extensor tendon here as it coalesces. It gives you an additional and different look if, as a tiebreaker, if you're unsure whether to call tendinosis or a degree of tear. This also gives a really good look at the actual joint itself, and I tend to kind of rely a little bit more heavily on this to see more subtle osteophytes, more subtle chondrosis, to comment on the degree of degenerative changes in both the radiohumeral and ulnohumeral joints. Coming across here, you can see the curved kind of cartilage here is nicely laid out for us. You can see the coronoid process and the olecranon as well pretty well here. And as you come all the way out, here's going to be the common flexor tendon at its insertional point. So now looking on the fluid sensitive, you can see this is pretty low in signal. There's no abnormality there. And then we're coming across through the actual joint space. No high-grade chondrosis or degenerative changes with either the ulnohumeral or radiohumeral joints. and we're coming across to the other side, and you can see how well you can see that tendon coming together here, pretty low in signal. Another common pathology in the elbow is going to be if there's olecranon bursitis, and you're essentially looking for fluid overlying the olecranon here. Or if you see any abnormal subcutaneous edema, sometimes you'll get some underlying marrow edema as well. This tends to also be helpful for seeing if there's any distal triceps pathology. You're looking for increased signal, thickening, potential tearing of the triceps. A lot of times these are avulsive injuries, and you'll get some retraction of the triceps tendon, and it can even rip off a portion of the bone that is a part of the ulna or olecranon. A common indication is going to be bicep rupture cases. The sagittal is going to be very helpful to measure the degree of proximal retraction of the actual bicep tendon. It tends to be a stump, and a lot of times along the stump where it'll retract to about this area, you can comment on if there is a hematoma, small, moderate, large, associated with it, the degree of proximal retraction, and you'll rely more heavily on your axial sequences to comment on, is there any bicipital-radial bursal fluid, which will extend along kind of the expected location of this more distal bicep tendon, and to see if the lacertus fibrosus is intact or not.